Hi, this is Mary Vukicevic and this video is about corneal disorders. There are many corneal disorders that can occur, but these that are listed here are the only ones that we will focus on in this lecture. So I'll be covering keratitis, keratopathy, corneal erosions, keratoconus and Arcus senilis. The reason that I've chosen these is because clinically these are probably the most relevant for orthoptists, and these are the ones that will be most commonly seen by you. So when you're considering these corneal diseases, there are some learning goals that you have to always keep in mind, as with all other disorders, and they are to analyse, identify and differentiate. So think about what changes are occurring in the anatomy and physiology of the cornea as we go through each disease or disorder. Identify the common diseases that are prominent in patients, and then construct a differential diagnosis if diseases or disorders look similar to one another. Okay, let's start with keratitis. Keratitis is an inflammation of the cornea, and there are several types of epithelial keratitis, and these are determined, the different types, by staining the corneal cells. And the different appearance of the corneal cells when they're stained is shown in this schematic diagram, and I realise that it's a little bit hard to see and read. However, I do have a link there for you if you want to have a look at this table in more detail. Now, you don't have to know all of these, and there are different appearances. It's just to give you an idea of how keratitis is identified on the cornea. And you will actually see some of these as I go through the different types of keratitis. For example, the second one, herpetic keratitis, which is what we're going to look at soon, and you'll see this particular shape appearance on the cornea. So it's just to give you a guide as to what happens to the corneal cells and how they look when they're stained. Now, as you saw in the table before, there are a lot of different types of keratitis, and I'm going to, in this lecture, focus only on two types related to viral keratitis, and they are herpes simplex virus keratitis and herpes zoster ophthalmicus keratitis, which is on the next slide. So, herpes simplex virus can lead to what we call herpes simplex keratitis. And there are two types of the virus that a patient presents with. Type 1 occurs above the waist, and you see that when you get a cold sore is part of the herpes simplex virus. And type 2 is below the waist presentation, and that's when the patient develops genital sores. So what happens after a primary attack of herpes simplex virus? The virus travels up into the sensory nerve, and it can remain dormant in the ganglion of that nerve. And eventually it's set off by things like stress or trauma or poor immunity. If you have a cold and then you develop a cold sore, which is why we call herpes simplex virus type 1 cold sore, or excessive sunlight exposure can also trigger the dormant virus to rear up and cause the cold sore. So what happens is a patient will present with mild or moderate discomfort of the eye if it actually gets into the eye, and they will experience redness, photophobia, watering and blurred vision. And then what you see is that the corneal epithelial cells swell up and a dendritic ulcer can appear. Now, the dendritic ulcer is shown here. This is on the right hand side, there's a picture of the cornea, and it's stained with fluorescein, and a cobalt blue light is shone onto it using a slit lamp. And you can see that dendritic ulcer, which looks like tree branches, there on the inferior part of the cornea. Now, this condition is usually unilateral, and will only affect the corneal epithelium. So luckily it doesn't leave the patient with a scar. You can treat this herpes simplex keratitis with antiviral drugs, but in this subject we don't focus on treatment at this stage. The other type of viral keratitis that you will commonly see in clinic is herpes zoster ophthalmicus, or HZO, and this is where the patient develops a recurrence of the chickenpox virus, which is called the varicella zoster virus, and you'll hear this referred to as shingles. And what happens is the anterior uvea and the stroma are affected, and like the herpes simplex virus, it lies dormant in the ganglion cells and has very similar triggers. Usually this happens actually in older aged people. The patient will present with quite severe pain because the deeper corneal structures are affected, and that's where there are more sensory nerves. And the patient will also usually present with a rash or crusting where the virus has infected the facial nerve or cranial nerve 5, and they'll have epithelial keratitis and dendrites similarly to the herpes simplex virus, but spread much more diffusely over the cornea compared to herpes simplex keratitis. How you tell the difference between the two is that herpes zoster ophthalmicus is associated with this rash or crusting on the forehead and around the eye, whereas herpes simplex virus is not, and herpes zoster ophthalmicus is associated with much more severe pain compared to the herpes simplex virus. I'm going to move on now to keratopathies. Now, there are various keratopathies that can affect the cornea, but exposure keratopathy is the most common, and it's caused by incomplete lid closure, and that's called lag ophthalmos, with drying of the cornea despite the fact that the patient has a normal tear production. Now, this can happen because of things like facial nerve palsy or reduced muscle tone, for example, in Parkinson's disease, or even a mechanical issue such as lid scarring the lids can rub against the cornea and cause this problem, or skin tightening of the lids as a result of eczema, or post-blepharoplasty. Blepharoplasty is a tightening of the lids, and if the lids are too tight, they can rub over the cornea a bit too harshly. Exposure keratopathy can also be caused by proptosis, where the eyelids are elevated, not closing properly, and the eyeball is protruding outwards. Now, what happens is prolonged exposure to the air without regular lubrication or sufficient lubrication causes the corneal epithelium to break down. And the image that you see here on the right is an inferior corneal defect, which is as a result of exposure keratopathy. And it's almost like the epithelium has torn away in that U-shaped section. Just above that, you'll see the dark area is the round pupil, in case you're lost in terms of where you are in the eye. The next corneal problem I'll discuss is corneal erosions, and recurrent corneal epithelial erosion is caused by an abnormally weak attachment between the basal cells of the corneal epithelium and their basement membrane. Things like minor trauma, just simply the lids rubbing on the cornea during sleep can cause an erosion, and the intervals that the patient experiences can be variable, and they can occur regularly in a short period of time, or patients can have recurrent episodes a couple of years after their first presentation. The patient will arrive and tell you that they're in quite severe pain, they've got photophobia and redness, and you will see an epithelial defect, and it may not always be present, because when you look at the patient under a slit lamp, they might have already healed, because healing can be quite fast and within hours. You can see on the picture here the epithelial defect where fluorescein has been instilled, and the patient is being looked at under a slit lamp, and the fluorescein has pooled in that area of cornea just in front of the pupil. Now, corneal erosion is a bit similar to exposure keratopathy, but it's definitely not as severe. And usually with corneal erosions, the irritation comes and goes, whereas with exposure keratopathy, it's prolonged exposure to the air without sufficient lubrication. Keratoconus is another corneal problem that you are definitely going to see clinically, and it's where there is presence of corneal stromal thinning. And what happens is the cornea protrudes and creates an irregular astigmatism. Both eyes are eventually affected in keratoconus, and the patient will present with unilateral impairment of vision, and that's caused by progressive myopia and astigmatism. The signs that the patient present with can vary a little bit, but you might notice an oil droplet appearance in the eye, which is shown here in image A. Image B shows vertical stromal stress lines, and you can see those little lines in the corneal stroma running up and down. This is the side view using a slit lamp. Or epithelial iron deposits, which are shown in image C, and then image D shows the corneal protrusion in a cone shape. Now, that is really once the keratoconus is quite developed. A very important method of determining whether the patient has keratoconus and what's actually going on is using topography, corneal topography. And on the left-hand side, I'm showing you a picture there of a normal left eye. Now, the images of the normal left eye on the left show the anterior cornea, and the right show the posterior cornea. And the colours yellow and green indicate moderate curvature of the cornea, or normal. So the cooler the colours are, the flatter that the cornea is. The hotter the colours are, the steeper the cornea is. On the right-hand side, we've got another left eye, but this one has keratoconus, and you can see the marked difference. The anterior cornea shows very steep areas just off the centre, and they're shown in orange and red. So it's quite a significant bulging of the cornea there. Now, this is just a very brief introduction to keratoconus. You are going to have to do some more reading on this condition yourself. And the final corneal problem I'm going to present here is Arcus senilis, and this is an opaque grey or white ring around the corneal periphery, and it's an age-related change. That arc or ring comes from lipids or fats and or cholesterol deposited in the cornea, and it's often actually associated with elevated cholesterol levels in patients. You're definitely going to see this in your patients clinically. It doesn't actually interfere with visual acuity, which is good, and there's no treatment for this. It's an age-related process related to fat or cholesterol deposits.